Thank you, thank you. It's a pleasure to be here. It's my first time in Arkansas, actually. I went around for Louisiana and Texas the other times, but I'm very, very grateful for the opportunity to be involved with a number of people here who are doing very interesting and important work around the problem of prisons in America, and which is the tip of an iceberg that includes a lot of other issues that come along with it and have to be dealt with, and that's as it should be, because they're all parts of the same iceberg. Crime, violence, racism, you name it, they all come together in this peculiar form of expression that we've developed in this country of putting endless amounts of people in prison. What that means and what's bad about it, what's good about it, what's going to happen about it is now an issue that's gone unanswered for close to 40 years. This thing started back in the 70s. So what I wanted to do was walk you through a little of this obsession that I developed because I worked with patients who started out as psychiatric patients. I worked in community mental health, and they became drug-using patients. Their identity changed in the 70s. Then they got AIDS in the 80s, and they all went to prison in the 90s and the 80s. And I simply stuck with this population, actually 20 years on the job, and then 20 years running programs, and then 20 years doing research on them. And it's a panorama of something akin to the history of smallpox or something like that. Because I'm not trained as an epidemiologist, I'm trained as a psychologist, but the epidemiology of public health come very naturally to any of us who are interested in populations. And that's one of the distinctions I want to try to make here is between individual models like medicine and crime and punishment and population-based collective models such as public health. And they're as different as the epidemiologist friend of mine, a woman says, it's not about the cow, it's about the herd. It's a fundamentally, now, some people have taken that too far, like the communists. There is no cow, there's only the herd. That's not true. One's made up of the others. But, we've gotten to a point where we had better start saying what's true and not true and saying it decisively. So let me show you a few things to put you in the picture of this phenomenon of incarceration in America and what it signifies for these issues, global drug policies and human rights. That's the framework in which I've been working with the support of the Open Society Foundation, with my friend Deanne Newell, who's here, who's responsible for my being involved in some of this work. And she does wonderful work in these same areas here in Little Rock. So, forward. So this is my book, the only one I've ever written. I'm doing another one now. And this came out of the experience of following these patients and understanding that the high rates of them in prison were a fact of their own, that they took on a role as what we call a determinant of public health. So the point of this was to try to understand and see if it was more than just a cute way of describing things, a public health model, what problems it might help us solve. So that distinction, I said, that crime and punishment is an individual model. Sorry to be so didactic, but I wanted to get some of these points across. That criminal justice and medicine have this in common. They really, it's case by case. And that's what you want as a patient, and that's what you want to do as a doctor. And it's the right way. But there is this other thing called an epidemic, which is dependent on the transmission between people, the social networks that people live in, the environment. And they're both true. They're both different sides of the same coin fundamentally, which is health of the species essentially. And mass incarceration, large-scale punishment, transforms punishment to a population phenomenon. This becomes a determinant of health. When you put 37% of all the black men in the United States into prison in their lifetimes, a scarring experience, a traumatic experience for everyone involved, whatever the reason for their being there. Because it's not just affecting the individual who goes to prison, you're leaving a very large imprint on the entire population of that's affected, which is all those families and all those. Let me ask a question of this group. How many people here have had a loved one, someone close to you, in prison? Okay. When I do that where I teach at John Jay, everyone raises their hands. And it's especially interesting because I'm often talking to kids, Black and Latino kids, who are on their way into careers in law enforcement and corrections and parole. And one member of the family is in prison and the other's getting a job in the industry. They both have jobs in the industry in a sense. And that's what's happened. There's one job for every prison bed in America, and that system does not let go of those jobs easily as we try to get people out of prison. I'm going to say a bit about the new movement, decarceration, a number of us are working on, to how do we turn this clock back and walk this beast back into the cave where it belongs? Because you can't have 2 million people in prison. Never happened before. So it even has reached the point where this Oxford textbook of public health, which is a venerable old textbook in public health, Oxford old, and for the first time they asked me to do a chapter on prisons for a public, sort of legitimating it as a public health issue, which was important for my ability to get grants to work more on this. But what we're talking about with epidemics is as simple as this. When you see a curve like this now, you always say, what's going on? What happened? What happened at that point? Because you see from, I don't know if you can, is there an arrow in here? Yes. This is 1975. You can't possibly see it. This is the number of people in prison going up to as high as 1.8 million at one point, from 2008. And this surge is what requires explaining. And there's always a story behind that kind of data for anything. Influenza, pregnancy, drug overdose deaths. It's a very, very loud signal about that something's going on, and you got to explain it, because to let it go on, if it keeps going, you're in even worse trouble. Here's another version of it, a three-dimensional version, which shows the the age is three variables: the age, the year, the birth cohort, the year people were born from 1910 through 1980, and the percentage of adults in that group who have ever been incarcerated in a state or federal institution. So it combines it takes this epidemic, it unpacks it by, first of all, you can see it wasn't like that until the people began being born around 1940 when I was born. And then this whole thing it blossoms after that. And it's especially, it's growing with age, because the longer you live, the more chance you have of going to prison. The lifetime probability of a black man going to prison in the US in his lifetime is now 37%, somewhere in that life. But most of it happens in the 20s. Most crimes are committed between 16 and 26. Most people get sent to prison for the first time in that age range. But the system has the ability to keep you coming back for more, recidivism. Now, you can see in New York State, where I work and have most data, that this in New York State shows the same as these big national figures, this rise beginning in 1960s here, in the 1960s, here, 70s here, and this is the incarceration in New York State. This is the rate, excuse me, and this is the numbers. In epidemiology, we use rates because the population changes, and you want to have the rate correct. But you can see that it's the same story, and that story is this rapid increase. So what happened? What happened here? And what happened here is this guy, Nelson Rockefeller, who's signing a bill here called the Rockefeller drug laws, which called for harsh mandatory sentences for drug users. In the face, this is 2 years, 73, 2 years after Attica, in which case he stood strong and he shot the guys down in the prison yard, killing 12 guards in the process, as well as 20 prisoners, and it was an example of being tough on crime. And he created this as an instrument of public policy, of political ambition, of a way to sort out the weak from the strong. God knows what you want to apply to it, but it definitely worked for him. And every other state in the Union emulated New York, including the federal government, in having harsh mandatory penalties for the drug problem. There was nothing new about the drug problem, except that more white people were using drugs in this period. That was a lot of it. And you begin to see the proportion of drug offenders fill the prison system, going up to 45%. In 1980 to 2001, it reached 45% of all new commitments to prison, new entrants to prison, were for drug offenses. And that doesn't mean being a drug kingpin. It means using drugs in the streets, selling drugs, buying drugs, all the things that drug users do. Now, the context of this, where I worked, the South Bronx in '75, it's Hiroshima, basically. It's a destroyed landscape, a destroyed environment, and the only industry left in there was the drug trade, and everybody was working in that business. I ran a clinic which had 400 patients in it near this site, and these buildings were all abandoned, but we had in that clinic we had 700 patients, drug users. And not this one, but one like it, suddenly had a terrible fire one night, and they collapsed, and suddenly we had 40 homeless men in our drug program who'd been living in this situation. So this is very desperate straits. New York, once again, has the highest homelessness rate in its history and the highest in the country. 50,000 people homeless in New York City now, many of them on the street. This is a map of that, and what it shows is the hotspots of New York, and no surprise, it's the South Bronx. For those of you who know New York, it's the South Bronx, and it's Harlem, it's East Brooklyn, it's parts of Rockaway. You get concentrations in these communities of crime, of violence, of overdose deaths, all the things you look at as a public health person pile up in these communities. And one of the things that Eric Adora, imaginative sociologist, did with this was to look at some blocks in the Brooklyn and look at the expenditure on prisons for those blocks. And he came up with something called the $1 million blocks. We could identify blocks in Brooklyn where people were very, very poor, that were $1 million to $3 million being spent every year on incarcerating people from those streets. And nowhere in the life of that community was there anything to address that as a shared problem, rather than my father is in prison, your mother's in prison, and so on. Okay, the racial aspect of this is dramatic. It's highly biased in terms of against blacks especially, but Latinos somewhat. And you see the difference in rates of imprisonment by race in 2008, and roughly 3 times as much for blacks as Hispanics, and about 5 times as much as for whites. So, and that's been a mainstay of the system for its history. Some details on that: the role of this is lifetime imprisonment rates. What's the chance in your lifetime? And if you are a black man with high school only or high school dropout, you have a 62% chance of going to prison, and that variable alone, college or not. For whites, high school dropouts. For whites, it's one quarter of that. Its impact on imprisonment, because whites have other alternatives very often. Okay, mass incarceration is a global policy dilemma, limiting disaster, evaluating alternatives. What I'm thinking about here is the drug problem in America is part of a global drug problem. We see that most directly in what's happening with the United States and Mexico at this time, where in the last 6 or 7 years, over 100,000 Mexicans have been slaughtered in the course of the struggles and battles to get access to the $60 billion drug market that's right across the United States border. That's what that's about. And working its way up from the growing fields of Peru and Ecuador and Colombia in South America through Central America as transshipment points, where everyone's involved in the trade to get the stuff up to the American border, and then getting it across the border with everything from tunnels to submarines. There's no end of ingenuity about going after this money, but it's $60 billion, a lot of money. And the idea that we might end the drug wars and thereby end a lot of violence in the world is emerging. I'm a member of a working group at the London School of Economics, and they put this publication called Ending the War on Drugs. It's the expert group on economics of drug policy, an economic orientation here. And these are heads of state in this group, or coming to talk with this group, are heads of state from many Latin American countries, and the ministers of defense and chiefs of police, trying to get a grip on the problem that they have because we use drugs here. And we'll pay $60 billion a year for them, which they can grow in their backyards there. It's a very dangerous combination. So the details of this you're probably, saturated with at this point. The stories of Colombia and now Brazil, the origins of this war, where in 71, public enemy number one was drugs. Nixon established the Drug Enforcement Agency. This is the beginning of the war on drugs. And with little understanding at that time that it would be an international matter. The French connection they always knew about. People knew that drugs came from Afghanistan, but they didn't think about the neighboring countries in Latin America very much. A lot of it had to do with the introduction of cocaine in the 80s, a very compelling drug for some people, a powerful antidepressant, a powerful energizer, and flooded the country suddenly. It had always been around in small amounts, but suddenly in the 80s, there were tons of it. Every bad marker went off the charts. Their homicide rate went up dramatically in that period in the United States. In fact, in the war on cocaine, the crack babies, the episodes, and the moral panic that was going on around it at that time, resulted in a doubling of the homicide rate in the United States from the period 1973, when the drug war started, through about 83, which is when the crack thing hits us. And suddenly the violence is climbing through this period. People are beginning to go to jail in large numbers for the drug offenses, but really what's percolating is the violence of it. And the homicide rates climbed dramatically over that 10-year period. They stayed there for 5 years and then dropped down in 93. So it's a 20-year period, 73 to 93, in which we have a doubling of the homicide rate in the United States. And if you take what that means for the number of additional people, had things not changed, how many extra homicides, and the number is a startling one. It's 200,000 people. There were 200,000 more homicides in the 20 years of the war on drugs than in the 20 years before or the 20 years after. And they happened here in this country, to U.S. citizens. And what happened is, at that point, the trade changed to be controlled by Latin Americans, and suddenly they were dying for our drugs. I wrote something about outsourcing homicide. Because the murder rates are, the violence of the drug trade has to do with who controls the distribution apparatus. So we keep hearing about this drug lord and that drug lord getting caught and killed, and it's never the end. They're always replaced by someone else. And what this has a lot to do with is the place of drug policy in the world. These countries that are affected by it have a stake in it, and they have a voice in it, and they won't be silenced, although they in the United States don't usually have a very open discourse about it. It's a lot of denial on both sides, a lot of embarrassment on all sides, and it just feeds into a pattern of influence and corruption in many Latin American governments and police forces, which is undeniable. So these are big problems, right? Now, Colombia, I want to go past, I don't want to dwell on this too much. Plan Colombia was American aid for President Clinton, put $1.3 billion into it, targeting the southern parts of Colombia because the drug trade was completely inseparable from the revolutionary movement of the FARC in Colombia at this time. And it's always the kind of thing that lends itself to exploitation by any insurgent group, because there's a lot of money around, there's a lot of corruption of people at borders, It's been said that if you wanted to smuggle a dirty nuclear bomb into the United States, the one sure way to do it would be to hide it in a barrel of cocaine, because you can always get a barrel of cocaine into the United States, apparently. And people who want to smuggle things in notice that. And so they talk about the hazards of a policy of taking essentially a free commodity. Anybody can grow this stuff in their backyard in Latin America and here in America. And so to dangle that kind of money out is very dangerous. Let me get to a little further on this. Brazil is the new victim of this because they're a very large consumer. It's a large market of 150 million or so in Brazil. And the history of violence in policing in Brazil is famous, and the corruption of the favelas and the management of the favelas is just a huge problem for a long time, and it's destroyed a couple of governments and killed a lot of people. And the drug business is one of the lubricants of that world. Let me go. So this poor woman is supposed to combat the drug traffic. Now, what I want to point out here is some of the United States relative to other countries. Where we stand on our incarceration rate is, way out of proportion. Russia and South Africa come close, but this is the median for all the countries in here. And we're an outlier in most ways, and it's not many areas that we outstrip China. The global rates of imprisonment are very substantial, red and dark red, and a lot of that has to do with drugs. Perhaps 80 to 90% of incarceration in most countries is drug-related. Now, an important philosophical point here. Niels Christie, who passed away last year, a sociologist from Norway, one of my inspirations and mentors, wrote a book called Limits to Pain, which is available on the internet for free. It's about 80 pages long. And he makes a very important point, and that is imposing punishment within the law means inflicting pain, and doing so deliberately. And when the state undertakes to do that, it's an immoral quandary, is the point he tries to make. And reconciling this with the effects that it has on human behavior and shaping morality is an issue, the intentional infliction of pain. So he says we have to confront this reality and find alternatives to punishment. Because all of us who have raised children know that punishment is one of the things you can do. Sometimes it works, sometimes it doesn't, but it's not the only thing you can do. But with a certain category of violations of custom, thou shalt be punished. And that's ancient law, I wouldn't call it wisdom, but it's certainly ancient. There's nothing new under the sun in crime and punishment in terms of what people think, what they do, what it means. Nobody wants to have their daughter kidnapped. Nobody wants to have their car stolen. Nobody wants to be assaulted and left to die in their blood in the street. So there's this natural law is the term that's used for these things. And everyone agrees you want to have an orderly society which provides security to people. And the trouble is that gets altered by the state taking on this role of a large-scale punisher. And one of the forms that takes, one of the most pernicious, is forced drug treatment. All over the world, many nations, institutions force drug users into treatment, which is indistinguishable from brutal punishment, even torture. Sorry. So here are some examples of forced drug treatment around the world. This is in Sierra Leone in West Africa, and these are the conditions where if you have, which is in all the, drug addiction as a disease is listed in all the international catalogs of disease, the international classifications of disease. The UN upholds that it's a health problem, addiction, and yet this is the approach to treating it in many countries, and calling it treatment. Military oversight, large crowds made of men especially, made to do slave labor, children in isolation who are still minors in detention camps, guys doing military-style exercise as part of their rehabilitation. So it's it's to crush people who do this, to give them a message that they're going to be suffered and maybe killed if they don't stop. And there are people who think that's just fine, because we won't tolerate having these people use drugs. And they'll go out and have a martini over it. Here's a policewoman in China in a forced labor camp. And it's a real 21st century version of a forced labor camp. But they had to put nets outside the factories to keep people from committing suicide. Now, the other thing is death penalty for drug offenses. There are about 25 nations which still have death penalties for different drug offenses. On a report from Harm Reduction International, a group that's been looking at drug policies for a long time I'm part of. And here are the high rollers: China, Iran, Saudi Arabia, Vietnam, Malaysia, Singapore. Between them have about 1,000 executions every year. The Chinese, there's no way to verify their numbers, but they're higher than that. But these are cases for small amounts of drugs. Let me show you one. There's no time to read this. But look, in Malaysia alone, a large country, marijuana, hashish, hemp, 77 executions for carrying marijuana across the border. If you go into Singapore, you'll see a line. If you cross this line, there's a garbage can where you can leave anything, any contraband behind. But if you don't, they promise you inside they'll kill you. Makes an impression. In Kuwait, people are hanged for drug offenses. Yeah, it's just a steady drumbeat of the total impunity in terms of human rights declarations of the United Nations, or rule of law, due process. None of it applies to these people, all in the name of treating the evil of drug addiction. I knew an attorney in the Bay Area once who used to defend drug dealers and win. And how can you do that? He said, well, what I show is that the things that the officials did to get these drug dealers into prosecution, things that the deceit they did, the things they set up, because the guys were drug dealers, it was true. But the things they did were far worse than what the drug dealers did. And I could convince a jury of that when you open up the human rights dimension of it and following due process. So human rights abuses in the name of drug control are distressingly common. That's the takeaway message. Now, decarceration, a new word. I thought I made it up, actually. You have all this mass incarceration, and how do you get rid of it? You have decarceration. It's like denazification, or detoxification, or decontamination, that kind of word. And it turned out I hadn't made it up, because I looked at Google this 2.5 years ago, and there were 10,000 hits 2.5 years ago. And among those were 20 books with the title Decarceration. One of them was from 1971 by a guy named Richard Scull, who's a sociologist at UC San Diego. And he was writing about a particular period in history. And, well, let me go back to this later. He was writing about the period in the 1960s where we closed all the mental hospitals in the name of community care. We were going to replace these 19th century institutions that were full of abuse and neglect and a terrible, terrible example, and were not therapeutic by any means. We're going to replace those with loving community care. Great idea, but the money for it never materialized. It was associated with President Kennedy's community mental health bill, and then he was assassinated, and the Vietnam War was eating up the money, and it never happened. They closed all these hospitals, and the people became the homeless. Okay, who were let out of these hospitals because there were no homes they could come to. If you have those of us who've had a mentally ill relative with no ability to get serious support for where they can live when they're out of control, destroy a household. So it was an abandonment of responsibility on a huge scale. And I want to show you this. Basically, the rate of the rate per 100,000 of institutionalized people in mental hospitals was up here at about 450, and then began to drop off sharply when they began this policy in the late 50s and reached its asymptote by about 2000. And it's replaced, the dotted line is the prison population. The prison population takes their place. And many of the same people, of course, although there were more women in the mental hospitals than there were in the subsequent prison population. And this phenomenon of having almost a constant for an institutionalized population, and institutions that are ham-fisted and are brutal and are inadequate to a job of a rehabilitative function. Now, crime keeps falling around the country, and we still sustain this very large prison population. There were 2 million people behind bars in the United States 5 years ago, and there are still 2 million people behind bars, although everyone's saying that we're cutting this down, improving the drug laws, getting more people out on parole, all those sorts of things. They're all true in fact, but when you look at how much is going on, it's a drop in the bucket. So a public health paradigm for decarceration, meaning how do we not only get people out of prison, how do we get the prison out of people? Because imprisonment leaves very deep scars on the psyche of everyone involved in the situation. And you don't just turn it off on getting. In fact, there's a startling fact that in the 2 weeks after release from prison, the mortality rate, the death rate among people who come out of prison is 10 to 12 times as high as any other period for that same population. And what's particularly interesting about it is that it's true in the United States, it's true in Canada, it's true in Australia, it's true in Britain. Different countries, different policies, yet that same result. And it suggests there's something about a stint in prison that damages you for re-entry to society and makes you very vulnerable. The causes of those extra deaths are number 1, drug overdose, number 2, homicide, number 3, suicide, number 4, heart disease. So they're complicated reasons for dying, but the fact that they cluster at a point when people get out of prison, all they've wanted is to get out of prison, There's a terrible case in New York of Keith Brower, a kid who spent 3 years in Rikers because he couldn't make $500 bail. And when he got out, he finished his GED degree, and he got good press, and everybody was rooting for him, and he still hanged himself. You know, the fragility of a person who's been through that kind of trauma. Very, very striking. And we can't, going back to Niels Christie's point about the imposition of pain and suffering on people as a civic project. It's a bad mix. So, President Obama grants clemency to 95 people. Good. I have one on the list. The list is 9,000 at this moment. And Bill Bratton, who's the police commissioner in New York, formerly Los Angeles, he's worried about 6,000 federal prisoners getting released, he says, because it'll be the largest one-time release of drug offenders who received harsh sentences, and they're saying now they can not have to serve those. But they don't like to do do-overs in the criminal justice system. And it's not happening so quickly that people are getting out of prison. He says, well-intended, but would raise a lot of questions. He likened it to the Massachusetts, the mental hospitals. This deinstitutionalization before was evidence that the country was not prepared to deliver on its obligations to the most vulnerable populations and stand by them in an hour of need. It's considered un-American almost to do that at this point. And Bratton, you know, the hard-boiled police commander, where were they all going? Where are the jobs? Where is the housing? Where is the ability to allow them not to become recidivists, to go back to prison? Because right now, 2/3 of them do go back to prison within 4 or 5 years. So you have this revolving door still. 1/3 of everybody in prison gets out every year. About half of those go back within 2 or 3 years, mostly on administrative failures of all the restrictions put on them by parole and probation. Another important group is the elderly in prison, okay? Very significant group of people serving long sentences, often for violent offenses in their youth, and with 30, 40, 50-year sentences, life sentences sometimes. And that population is growing. It's the fastest growing population in the prison is those over age 50. Report from Human Rights Watch, old behind bars, the aging prison population in the United States. You see it, you know, every day. And there are calls for compassionate release and medical parole. I looked at one neighborhood in New York, Upper Manhattan, where Columbia is, and Washington Heights, 545 prisoners over the age of 55 had been released in the previous year back to that same community, and there was nothing there for them. Their suicide rate is way up there. In that, what's that famous movie, the Shawshank Rebellion, the old man in that? It's that story writ large. Recent report from Brennan Center, the reverse mass incarceration, the sense of, put this thing behind us and get beyond it. So we're in the early days of that struggle, and I'm delighted that people at the Clinton School are interested in plumbing this a bit. Just a little reference here, and I'm going to stop, because I had spoken with Deanne, my friend here, about the drug use problems and drug injection and heroin, which is coming back big time because of opiates, and the role that has in AIDS. So you have an AIDS outbreak in Arkansas and another one in Indiana next door. And it's a replay of what we first learned before we knew about the way in which AIDS spread. And then, the background of the conflict with the police, and the police are the enforcers of the drug laws. There's better jobs for everyone to do, and the solutions to drug policy issues are there before us. We can treat heroin addiction with heroin if necessary. I worked in a program in Vancouver which had 3,000 patients who came in and used heroin on the spot. Never went outside, never got used heroin outside because they could get it on the medical plan there, and safe injecting, no HIV. If they overdosed, they were rescued. And what's wrong with that? Well, you want them to stop using drugs? You want them to have a meaningful life? Well, surviving is a good step in that direction. And the survival rate for that population that's the bottom line in public health. So, going back to the end, we're in a new phase of this epidemiology. We're at a chronic stage, chronic recurrent condition, like an autoimmune disorder in a way. And we need to begin to explore new avenues to address the drug issue, both clinically, individual cases. Those of us who have had a family member with a drug problem know how unreasonable the system is, how expensive it is, how inaccessible it is. For drug treatment for an adolescent, which is the most common situation that's needed. And there's a very, very disturbing movie called The Business of Recovery. And it's a serious piece of investigative reporting about these programs that adopt the 12-step method that AA has been so famous for, justifiably, which is a system based on no money and and support, social support from groups. And if you know people who've been in AA, it's tremendously effective and helpful for people. But it got carried over to this corrupted world of drug addiction and the markets therein and the criminality associated with it, and it's busted. And so they use this model, kind of a 12-step light, to approach populations of people who can afford to pay $1,000 a week. No, it's $1,000 a night, excuse me, for treatment. And they went through a review of these programs with a couple of young men and women who had gone up for the program. 3 of them, they showed as example, 2 of them had died by the end of the filming for failures, by overdoses, because of the failure of the programs. But at the very end, the filmmaker ended with the salary levels of the executive directors of the program, which ranged from $295,000 to $1.25 million a year. And that's what we call a racket. And they made up statistics about their success rates. They even had 5 different accrediting agencies that they'd fabricated out of smoke and mirrors that would give them certificates like you see on the doors of certain businesses saying how good they are. These are all signs of a systemic corruption. And a problem like drugs is an opportunistic adventure for the most corrupt among us. So let me stop there. Thank you all very much.
We have time for some questions. If you raise your hand, we'll get a microphone to you. Let's just stay at that table.
I didn't see any correlation in your statistics about post released from armed services, I know
Yeah.
after Vietnam, and now returning veterans from Afghanistan and Iraq. Could you say something about that element?
I'm glad you mentioned that because it is, I work with an anthropologist friend, colleague, on VA studies, on PTSD and returning war veterans, and it's a very similar pattern. We happen to have a cohort of former war veterans who used drugs before, during, and after their service, and were in prison in many cases before they take people in the military to just take. But the same thing happens. The PTSD, the perseverance of PTSD, and its, what's the right word? Its sensitivity to provocation. The stories of hearing loud noises, the sense of threats, how deep that runs. It has a lot to do with the PTSD syndrome we see in former prisoners. And what's striking is they have to harden themselves when they're in to get by, but once they're out, and they have their comrades, that's a common element in both. It's a man's world, and it involves use of force to survive. And that may keep them focused. You know, think what's the word? Evolutionary psychology, in this case, because there's a lot of similarities there, and there is a high mortality rate for veterans in the period right after release.
Hi, my name is Kristin Alexander, and I'm a first-year student here at the Clinton School. I'm really interested in getting into brain injury policy and advocacy. And if you look at studies on incarcerated individuals, a lot of them suggest that around 60% of incarcerated individuals have suffered some kind of head injury.
Right.
And those people with brain injuries are often more susceptible to drug and alcohol abuse as well. And so what role do you think that actually those head injuries can be playing into this epidemic as well?
Well, that's certainly, what's the rate of head injuries in normal kids who don't go to jail but do play hard and football, see the football stories. So I don't think that's zero. I don't know if it's 60%. I've worked at Rikers Island in New York, and my hospital did the health service there, and I worked in it. And what we mostly were encountering was the effect of brutality by the guards and the difficulty of laying that at the door of the guards because of their powerful union that defends them fiercely around this. And the traumatic brain injury is that the prevalence, how much of it is it's very, very common. And it does mess up a lot of your abilities to function, and the drug interactions are real, and they're another reason to have some one of the new terms that's come out that's interesting about drug. There's harm reduction. Any of you ever heard the term harm reduction before? Because that's the newest alternative to zero tolerance. Just say no, which goes back to Mrs. Reagan. But the new concept that's developing is called substance use management. And the implication there, as opposed to zero tolerance, thou shalt use no drugs, which is an illusion, is that you can, the reason people are using drugs before they become addicted is they get something positive out of it from their point of view. If they're depressed, it makes them less depressed. If they're nervous, it makes them less nervous. People who get prescriptions and go to expensive doctors, that's the concept there. And increasingly, the marketplace of psychoactive drugs that people use is the pharmaceutical marketplace, the most striking example being the opioids, the opioid painkillers, OxyContin, and those, which have flooded the market far beyond their proper usage because they're so lucrative. It costs nothing to make these drugs, and you see the prices that are charged for them. So what happened in the case of the opioid painkillers is that they became so ubiquitous, they created a new generation of addicts to opiates. One of the things you should know, a technical thing, is that if you have an addiction to this molecule, the opiate molecule, there's a receptor in the brain that can only see that molecule, and it turns on whatever it turns on. It doesn't matter where that molecule comes from if it's an opioid molecule. It's a particular chemical unit that you can get it out of morphine, out of coca, out of poppies, but you could also synthesize it. Methadones are synthetic, Demerol is synthetic, but they build this molecule up, and it pushes that button very effectively. So what happened is, most recently, is that the large number of painkillers being used generated a new generation of opiate addicts. And the doctors couldn't continue to prescribe because they're policed by the DEA on writing prescriptions for these potent narcotics. Because the job of the DEA is to keep narcotics under their thumb. And so there's a street market in counterfeit and diverted pharmaceutical drugs, and then that's followed by a market in heroin, which is a very effective version of, and is cheaper actually. And give you a sense of scale, there's been a 400% increase in drug overdose cases in New England, Vermont, New Hampshire, Maine, Massachusetts in the last 4 years, as these drugs flood into the community, and people who'd never used opiates before, and they didn't get into using opiates consciously as drugs for pleasure, they were using for pain. But they are very powerful anti-anxiety drugs and very powerful tranquilizers, and as well as being painkillers. In fact, Dr. Dole, the man who discovered methadone, insisted he defied anyone to distinguish between the pain of addiction and abstinence from a drug and any other kind of pain, because the button that it pushes is to make it go away. And that's where Narcan comes in. You may have heard about this drug that is the cure for overdoses. So in the face of overdoses going up all over the place, we've used this drug for 30 years in medicine, in emergency rooms, but began to use it with policing. And it's offered a very promising bridge to developing the role of police as first responders, which is one of the major jobs anyway. And you can imagine the police are looking for roles now that will gain them some support in the communities. And this is a very effective, almost magical drug, because it does nothing except reverse overdoses. It has no other effect. And the police in New York are now going around saving lives. A town up in, where was it? Somewhere in Connecticut, the police had saved 93 lives, 93 rescues. And every one of those calls for an overdose kid used to be a confrontation between the kid's friends, who would often abandon them when they could have survived and they didn't, because they were afraid of what the cops would do to them, because they were looking for who got the drugs and so on. So the invasion by opiates again and injecting drugs has carried the HIV epidemic back. And there are resurgent epidemics in white middle-class communities. That's the other big difference. So in New York, the highest rate of overdose deaths now is in Staten Island, which is historically a white working-class community. What was the question about that? I didn't. What made me go there?
Brain injury.
Well, one's fine, mine. Sorry.
John, last one.
Appreciate you being here, and thanks for the very interesting presentation. You mentioned New England, and to my mind, and a good example happened last week or so of the fundamental misunderstanding that I just would be interested in your thoughts about how to deal with it. The mayor of Manchester was being interviewed.
In Vermont? Vermont?
Manchester, New Hampshire.
Oh, okay.
Largest city, I believe, in New Hampshire, was being interviewed about heroin. And he said, yeah, heroin's a terrible problem in our city, in our state. And he said he thought the right solution to the problem would be to keep heroin from coming into New Hampshire. That was his approach, that the way to deal with the heroin problem in New Hampshire is he didn't give much specificity, is just what strategy he would use to, quote, keep heroin out of New Hampshire.
Heroin be gone.
Yeah, right. but
Works every time.
But this is the mayor of the largest city of a state that has been documented, and you've just said has this. And when you have that level of misunderstanding, I don't know what.
I don't know if it's
It's hard to know what to say.
I don't know if it's misunderstanding, but it's right up there with keeping Muslims out. It's the same kind of idea. You know, it sells, but and no one's making you deliver on it. Because in fact, the thing about heroin that's particularly interesting is that it's the most manageable of addictions, because it's not a toxin the way in which amphetamines and cocaine are, tobacco is, alcohol is. People I ran a methadone program where I had patients who received doses every day for 30 years of an opiate that would kill you or I in 10 minutes. The opiates themselves are not toxic to the human body. There's mechanisms for adapting to them, and there are people who can be maintained on them. You get very sophisticated addicts now. I call them the .com addicts. And they'll explain about how their addiction is because they have a endorphin imbalance in their brain. You can make it abstract. And there's all these people waiting around to do just the opposite and turn it into a very meaningful statement about your soul. A lot of moral entrepreneurs hover around the world of drug use on all sides. And so it's not surprising we haven't done well. But when the only response was the criminal justice response to most of these, the move of marijuana is very significant. The progressive legalization and legitimization of marijuana is very significant because it's the most commonly used drug, illegal drug. And it's, turns out, has some very, very positive features about it. Anyone who's had a family member with cancer and chemotherapy knows about the ability of cannabis, some of the molecules in it, to affect nausea. And in fact, the Israelis have separated out that piece of the cannabis array of different pharmaceutical groups and can give the anti-nausea effect without any mood alteration at all. Also success now that because you can it's been very hard to do research in any drug that was illegal. LSD, for example, had been used in psychotherapy when it was originally introduced. Ecstasy is another drug that has a lot of very interesting potential in psychotherapy, and there are people beginning to do that again. These drugs are very old, and people have experimented with them over the ages without anyone paying attention at all. The mushrooms from Mexico and those kinds of things. And what's happening is those explorations are being brought into the laboratory and into the clinic now. So New York has just opened its first medical marijuana programs, and there's a lot of research going on about, well, how much it's good for multiple sclerosis, it's good for seizure disorders in children. How much, when, what kind, what else do you do? Good clinical research. It's finally happening. And I think that the opiates are the other one, with all these painkillers that people are addicted to. We can transfer that addiction to methadone or buprenorphine, which is another type of long-acting oral opiate that has no ill effects on the body. You can maintain people at a dose where they don't go into withdrawal and they don't get high, and that's what most want. The first cohort of patients who used methadone in New York City that my patients were part of, 10,000 patients, who had entered the program in the mid-'60s and stayed on into the '70s when AIDS was first spreading in the population. None of them had AIDS. None of them were infected with the AIDS virus, despite the fact that they had been injecting drugs for 20 years, but they had stopped injecting when they started using methadone. It's one of the big benefits of an oral medication. You don't risk the transmission of bloodborne diseases. So, we can begin to chip away drug by drug and hopefully get the pharmaceutical industry under some control, because their aggressive marketing of these drugs is very, very destructive.
Well,
in fact, there's a movement afoot to try to ban medical advertising again, like we used to have. Only a few countries allow medical advertising, like we have, and they're seeing vindication in what's happening here.
Thanks so much for visiting us here on short notice. Thank all of you for coming out. If you have more questions, please come up and chat with him later, and we'll see you at the next one. Thanks.
Thank you. Thank you, everyone.